Hey everyone, and welcome. If you're heading into your PEDS rotation, you've come to the right place. Today, we're going to tackle two really critical congenital heart defects, ones where blood takes a dangerous detour and actually skips the lungs. This is stuff you absolutely need to know, so let's jump right in.
So here's our game plan. First, we'll get a handle on the core problem itself, what we're calling the oxygen detour. Then we're going to open up two case files. First, tetralogy of Fallot, and second, tricuspid atresia. And we'll wrap it all up with the most important part. What is your role as the nurse? What are those critical interventions you have to have in your back pocket?
All right, so what's the fundamental issue we're dealing with here? It all comes down to conditions with decreased pulmonary blood flow. And in the simplest terms, that just means not enough blood is making it to the lungs to get oxygenated and ready to supply the body.
Which leads us to this central question. I mean, really think about it for a second. What happens when that blue, deoxygenated blood, the blood that's supposed to get a full refresh in the lungs, takes a wrong turn and gets pumped out to the rest of the body instead?
Well, the answer is a phenomenon called a right-to-left shunt. Think of a shunt as an abnormal shortcut, and in this case, it's our detour. Instead of following the normal path to the lungs, that deoxygenated blood flows from the right side of the heart straight over to the left side. It completely bypasses the lungs, sending oxygen-poor blood right back out into circulation.
And the most visible, most alarming result of this whole process is a key sign you'll be assessing for as a nurse: cyanosis. You know that bluish tint you see on the skin, the lips, the nail beds? It's a direct result of that deoxygenated blood running through the body. It is the classic sign of these types of heart defects.
Okay, let's open up our first case file, tetralogy of Fallot, or you'll hear it called TOF all the time. The key word to remember here is tetralogy. Tetra means four. So this isn't just one single problem, it's a combo of four different defects all happening at the same time.
So let's break down these four parts of the puzzle. First up, you've got a ventricular septal defect, a VSD. That's just a hole between the two bottom chambers of the heart. Second, there's pulmonary stenosis, which is a narrowing of the pathway to the lungs, making it way harder for blood to get through. Third is what we call an overriding aorta. The aorta has actually shifted, so it's sitting right over that hole, the VSD, and it's pulling blood from both sides. And finally, right ventricular hypertrophy. Because that right ventricle is pumping so hard against that narrow pulmonary valve, its muscle wall gets super thick, just like any muscle that gets overworked.
Okay, now let's look at how these four things create the perfect storm. That pulmonary stenosis acts like a major traffic jam, right? It makes it really difficult for blood to get to the lungs. So what does the blood do? It takes the path of least resistance. It flows right through that hole, the VSD, and gets sucked directly into that overriding aorta, which then pumps it out to the body. And there it is. That's your right-to-left shunt in TOF.
Now, for your assessment, the hallmark sign of TOF, the thing you absolutely have to recognize, is something called a TET spell. These are sudden, really scary episodes where the baby becomes deeply cyanotic. They're often triggered by anything that makes the baby need more oxygen, like crying, feeding, or even just getting upset. In older kids, it can even cause them to faint. And you might see something really interesting. A toddler will instinctively squat down during one of these spells. It's their body's natural way of trying to push more blood to their lungs.
All right, on to our second case file, tricuspid atresia. Now, if TOF was a complicated four-part problem, I want you to think of this one as a single critical roadblock, a completely blocked gateway. That word atresia, it just means a normal opening is absent. And in this case, it's the tricuspid valve, the door between the right atrium and the right ventricle. It's either completely missing or it's sealed shut. So you have a total dead end, deoxygenated blood flows into the right atrium, and then it has nowhere to go. It can't get to the right ventricle to take the normal route to the lungs.
So you have to be wondering, how does this infant survive at all? And this is the really wild paradox of tricuspid atresia. Other defects, things that are normally problems, like an atrial septal defect, an ASD, or a VSD, they actually become life-saving detours. The blood has to shunt through these other holes to get over to the left side of the heart just to find some alternate path to the lungs.
So when you're doing your assessment, you're going to see several key things. Cyanosis is going to be a big one because there's so much mixing of deoxygenated blood. You're also probably going to hear a heart murmur from all that turbulent blood flow. And you'll see signs of chronic low oxygen, like poor growth and, over time, clubbing of the fingers and toes.
All right, now for the most important part. This is where you come in. let's really focus on the critical nursing interventions. How do you manage the crisis when it happens? And how do you support these incredibly fragile infants and their families?
If you walk in and see a TET spell happening, your number one immediate life-saving action is the knee-chest position. You bring that infant's knees up tight to their chest. Now, why does this work? It physically increases what we call systemic vascular resistance. It's kind of like kinking a garden hose for a second. That increases the pressure on the left side of the heart, which helps force more of that deoxygenated blood to go to the lungs where it's supposed to. Remember that toddler who instinctively squats? They're doing the exact same thing. It's such a simple maneuver, but it's incredibly effective.
Okay, for many of these newborns, their survival literally depends on a little blood vessel from fetal life staying open. It's called the ductus arteriosus, and it acts as a secondary pathway for blood to get to the lungs. To keep that little door open, we use a continuous IV infusion of a medication called prostaglandin E, or PGE. PGA is basically a lifeline. It keeps that pathway open and maintains blood flow to the lungs until the baby can get to surgery.
But, and this is a huge but, you have to know that PGE is a very high alert medication. It has some really serious side effects, and the biggest one is apnea. The infant can just stop breathing. Because of that risk, pretty much any infant on a PGE drip is going to be intubated and on a ventilator for safety. Your monitoring has to be absolutely constant.
And beyond those big dramatic moments, your day-to-day supportive care is vital. You're going to want to cluster your care. Do everything at once so you can give the infant long periods of rest. They have zero energy to spare. High-calorie feeds are a must to help them grow. You'll do everything you can to keep them calm and minimize crying to prevent those TET spells. And maybe most importantly, you're the one who starts preparing the family for the very long road ahead, which is going to include multiple surgeries and lifelong care with a cardiologist.
Okay, so let's do a quick side-by-side to really lock in the key differences. Tetralogy of Fallot, that's the four-part structural problem causing that shunt through the VSD, and its hallmark sign is the TET spell. Tricuspid atria, on the other hand, is all about that single blocked valve, which makes other defects like an ASD or a VSD absolutely essential for the baby to survive.
And that brings us to a final thought. We've gone through some pretty complex anatomy and the critical care you'll provide. But as nurses, our job goes way beyond the bedside. So I'll leave you with this question to think about. Beyond the operating room, what do you think is the most critical long-term challenge for the families who are caring for a child with a complex cardiac condition like this? Thanks so much for joining me today.